All right, thank you so much for joining us today. Today we're going to go over some drug titration, but before then, we're going to go over some concepts that we must understand. For example, what if you get a question that says you're using HAMD to assess a patient with MDD and they present to be persistently high after 8 weeks? This is what the guideline kind of says. First, you must understand the scenario. This is how to approach those questions. Second, you must understand what even MD is, or what is low and what is high. Remember, I taught you, well, if you have not been to my assessment class yet, that's okay. I show you how to actually remember your skills and how to keep them in your brain for the test, because you don't want to be trying to memorize every number. You will not be able to keep that in the brain. Interpreting the results. Teach how to interpret MD scores and what is persistently high and what is not. Consider treatment options. You want to discuss different treatment options. Do you want to adjust the dose? Do you want to switch to another class? Do you want to augment the therapy? Do you want to do ECT? Now, making this decision is not based on a guesswork. However, on the exam, they're going to make two options really obvious, things that you just won't do. And then you have to just kind of play around the rest. Now, there are guidelines, however, that will give you the straight answer. But those guidelines can only be referenced in real life. And I'm also going to show you some of those guidelines, but we can't really go too deep into it because pharmacology is not the only thing that you're going to be testing on. You know what I'm saying? When you do, after you pass your exam, when you come to my experts group, we're going to teach you everything about guidelines. In fact, we start the experts class next week, Thursday. That will be the second class we're starting. But anyway, decision making. Decision making, explain the rationale behind what you're picking and why you're picking it. Because even though there are guidelines that guide us on how to actually pick this treatment, we still don't, it's not set on stone. Does it make sense? It's still going to vary from patient to patient. Now, the second thing we're going to talk about right now is what if you get a patient with generalized anxiety disorder that exhibits moderate anxiety symptoms despite the long-term treatment for like 6 weeks of SSRI? What aligns best with what you're going to do? So first, you want to understand what GAD is. Second, you want to understand what GAD-7 scale is. Second, you want to know how to interpret GAD-7. Third, you want to know how to pick your treatment option. These are the 9 steps to follow to get to your answer. But now, when you get to number 4, it's got a little bit of a hiccup to it. Why does it have a hiccup to it? It has a hiccup to it because there are guidelines that support your decision for step 4. But again, I will kind of glaze over it and introduce you to it for board exam. I will not go too deep because listen, when I say guidelines, what do I mean? We have NICE guidelines, we have CANMAT guidelines, we have APA guidelines, we have POD guidelines for schizophrenia. So we have all kinds of guidelines. And you really cannot potentially know everything about every disorder, but you're going to have a good idea on the exam because on that exam, you're going to see 2 options that are definitely not going to be the answer. And that's going to be your approach to this test. Now, decision making, explain the rationale behind the treatment options that you're picking. Now, let's get started with questions. So, the last time we did this, I actually allowed students to do it because I'm recording this piece. I don't want student voice in there without my prior permission, and I never got that. So I'm going to have to read this and make it interactive, though. So the interaction now is up to you. If you want to say something, just know that your voice will be recorded. If you don't want to say something, just drop your answer in the chat. So using the Hamilton Depression Rating Scale, a patient with major depressive disorder scores persistently high after 8 weeks of treatment with SSRI. What is the next best step? A, increase the dosage of SSRI and reevaluate in 2 weeks. B, switch to a different class of antidepressant and reassess in 4 weeks. C, augment with a medication from a different class and reassess in 4 weeks. D, refer the patient for electroconvulsive therapy due to treatment-resistant depression. What do you think? Can I give you just 1 minute? Think about it. Drop your answer in the chat or say something. All right, so thank you so much for your participation. So now, let's quickly look into what we're going to take out. I think I'm seeing something like C and D will be out. If C and D is out, so now we have A and B that are very, very close. According to the guideline, okay, whenever we have tried somebody on a 8 weeks regimen and they are still persistently high, if we have the, wait a minute, you say you want to take out C and D? I think that would be that. Let's reconsider that. And the person is persistently high. The best thing we can do is really to see why it's not working, because it's not easy to just leave one drug for longer than 8 weeks and expect any kind of a change. So there is a word called augment. Now, when you augment, you are adding to this to make it more efficacious. The way I normally explain it is, I like to say, I normally use Aveeno cream for my skin, but because my skin is so dry, I now have to add Vaseline to make this really work. I'm not going to DC the Aveeno right off the bat because I know the Aveeno is doing some work too, but I'm going to go ahead and do something with the Vaseline to help my skin better. Similarly, this SSRI may just need a little help, and that is where the augment is. So if you have to eliminate something here, I'm going to eliminate A and I'm going to eliminate D. So why am I eliminating D? D is an extreme case. So I'm only going to keep B and C, and the final answer is going to be C. Okay, so but let's see what the guideline actually says. Did I have the, okay, I do have the guideline for this. Augment with medication from a different class and reassess in 4 weeks. When a patient shows inadequate response to SSRI, augmentation is usually the best thing to do. This is a guideline backing it up. So what are those guidelines? It is intelligence to say, okay, maybe you're rounding with other doctors in your job, and they always put down NPs. You're going to say, okay, according to APA guideline and CANMI guideline, this is what and what and what we're supposed to do. Then they're going to respect you for talking like that because they know that you are just not guessing. A lot of guessing is going on in psych. Therefore, a lot of treatment also vary. Now, if a treatment vary because of from patient to patient, is totally expected and normal. But if it's varying because we're doing things that we think, that's not good. And then you want to stand out and do what the guideline says. And that's what the guideline says. So why not other options? If we increase the dosage of SSRI, if the patient has already been on the therapeutic dose for 8 weeks without improvement, increasing the dose is most likely not going to touch the patient. Now, switch to a different class of antidepressants. Switching medication is considered if the patient has poor tolerability and is zero response. That's not the case here. Then the last option is wrong because ECT is just an extreme case that we use for resistant depression or suicidality. And that is why C is the final answer. All right, question 2. After initiating treatment with an antipsychotic schizophrenic patient, the patient's brief rating scale scores improve initially but plateau after 3 months. Okay, now with patients, with persistent, excuse me for that alarm, with persistent positive and negative symptom, what should the nurse practitioner consider? Now, this is what? Where is this positive symptom coming from? Okay. Well, nobody wants to talk because of your voice, right? Okay, it's coming from the mesolimbic pathway. Negative symptom is coming from what?
Mesolimbic.
No, but what about the negative symptom? It's coming from mesocortical. Okay, so now we know that we have schizophrenia in our hand. So let's look at A, increasing the dosage of current antipsychotic and reassessing in 6 weeks. B, switching to a different antipsychotic from the same class and reassessing in 6 weeks. D, adding a mood stabilizer as an adjunctive therapy and reassessing in 6 weeks. D, referring the patient for cognitive remediation therapy due to inadequate response to medication. What do we think? Ooh? Okay, let's remove. Guys, don't forget my strategy of approaching this question. And in fact, all exams, try to remove 2 first. What 2 will you remove? That is important. That strategy is important for this kind of question, please. So you don't get confused. Huh? What will you like?
A and D.
You want to remove D? You want to remove D?
and
What about C?
Removing B and D. No, A and D.
Why won't you remove C and D first?
I'll remove C and D first.
Because this is a mood stabilizer.
We're starting a mood stabilizer.
I want to target these things, right? So let's remove C and D, right? So let's see we have A and D, A and B. What do you think your final answer is going to be?
I'll take B.
You will take B, but are you making the intelligence guess to take B? Like using your questions to get what you want? It's already plateaued, and this is 3 whole months. This is 3 months. So the same rationale here, why we cannot increase this one We can't
Yes,
increase
it's
this
the same
one.
rationale on the
It's
other
the
side.
same reason why we
So
cannot
I
be
choose the B.
increasing this. Now, if you're giving me 2% milk, maybe that's a bad example to give. Yeah, maybe if you're giving me 2% milk and I don't know, and my bone is still brittle, maybe you might want to go ahead and switch me to 4% milk. I don't know if it exists or not, but I'm just saying that's the kind of a thing that is going on here. So for a long time, I've been on one thing, then you want to go ahead and make a switch here. Switching to a different antipsychotic from the same class and reassessing in 6 weeks seems to be reasonable. Again, some people will do otherwise. They will do A. If they don't have anywhere or for any reason they cannot do something. But if we can do something, we're going to be switching. So switching to a different antipsychotic from the same class and reassessing in 6 weeks. If a patient shows inadequate response or plateauing of symptoms keep getting worse, that's plateauing of symptoms, okay? Switching to another antipsychotic will make a patient feel better, or we can get to a therapeutic dose in that situation. Let's look at question number 3. A patient with generalized anxiety disorder exhibits moderate anxiety symptoms in 6 weeks, despite 6 weeks of treatment with a selective serotonin reuptake inhibitor. Which action aligns best with generalized anxiety disorder? 7-item scale, GAD-7. A, increasing the dosage of SSRI and reassessing in 4 weeks. B, adding cognitive behavioral therapy to the treatment regimen. C, switching to a different class of medication, such as serotonin or epinephrine reuptake inhibitors. D, augmenting with low-dose benzodiazepine for short-term relief of acute anxiety symptoms. Generalized anxiety disorder, moderate anxiety symptoms, despite 6 weeks of treatment, SSRI, which action aligns best. So you just have to do your best too, because different guidelines will say different things here. But what is your best answer to pick?
I would cancel B first.
Before you pick B, what do you want to take out?
I want to take out D.
You want to take out D? Let's talk about moderate anxiety. Now, this is the deal. Let me quickly give you a hint here. When a patient have mild anxiety, mild depression, mild anything, what do?
We use CBT.
We use psychotherapy. When a patient have moderate to severe anxiety, moderate to severe depression,
CBT or pharmacotherapy.
not or, and at that point we're introducing chemical. So we're doing pharm here. Anything less than pharm, you will not pick it. So what is out?
B.
So B is out.
B and D is out.
Do you see the point now? Even though we will not know, we can never know, you can never know all the guidelines for this test. We have to start looking for hints like this to guide you on the exam. And that's one of the hints right there. So you know B is out. You don't need to know guidelines to know that. We just have to know your content for that one. So now what about A and C? What will you now pick?
I'll pick C.
Okay. So now you're able to make a decision because you have been able to get rid of 2 answers. That is a strategy that comes with knowledge. No strategy without content, absolutely not. That's because you know that mild, you're not going to do CBT. So moderate, you're not going to do CBT, is out. D, you know that you're not going to do benzo. Listen, benzo is one of the drugs that you want to run away from on the test. Why don't we like to put people on benzo?
Addiction and sedation.
Addiction potential. Let me tell you something quickly too though. According to Stoll's Psychopharmacology 4th edition, benzo is actually one of the first-line treatments. He gave 6 or 7 first-line treatments, and benzo is one of them. But it doesn't mean that we go with what every book says, right? We have to make an informed decision based on guidelines. According to clinical guidelines, benzo is the least thing that you want to pick for a patient. So what is the final answer now?
C.
Absolutely, 100%. Are we all agree now? Can you say that now, even though you don't know the guideline, you have never seen the guideline, you have never touched the guideline, but you're able to decide, and that is the final answer. So that ends our drug titration questions. Honestly, the same approach. See, it actually was just a few questions. That same approach applies to every question that you're gonna see. All right, so that is it with drug titration. Don't forget to spread the word. This is our website. We go through content. You come down here. My office hours is right there every Fridays from 9 a.m. to 12 p.m. Eastern Time. If I'm not there, you go ahead and call me around that time, because if there's nobody showing up, I just kind of leave the office, temporarily. You come in here 347-901-6037 or email info@npcertificationacademy.com. We offer PMHNP, FNP, AGNP, NCLEX exam review, and our study guides are right here. And this is just for our students. Pillow package, pop-up book, crystal clear edition is just reserved for our students. And don't worry, you're in the right place. You're gonna pass your whole exam. You stay positive. Maintain that positive attitude. You will pass this test no matter what your experience has been in the past with exams. You are in a place where you're going to understand it. When you understand it, you're going to see it. Have a wonderful day, everybody. Dr. Kehinde Elisha speaking here, founder and CEO of FNP Certification Academy. Thank you.